down in Kent in our mental health trust. So the session that we're going to talk today is covering off introduction to NHS costing and PLICS. So I'm just going to pop some slides up that will be circulated to you afterwards, and that's what I'm going to talk through with you today. So hopefully you've got sight of those on your screen.
Yeah, I can see those.
Fabulous. Okay, so what we're going to talk through, we've just got 45-minute sessions. So starting off with what is costing, so giving you a bit of an overview. What do we mean when we talk about costing? Why is it important, and how does it support us in the NHS? Understanding the patient journey and how do we cost that journey? And then most importantly, how do we use costing to improve patient care? So how do we take it beyond just being a paper-based exercise and actually adding value to what we do? I'm then going to talk a little bit about KMPT, that's the organisation that I work for, and our deep dive approach and what we've done locally. And of course, we'll allow some time towards the end for any questions that you want to ask. Sophie's with us, so if there's anything that kind of you need to ask as we go through, I'm sure she'll help as well, but I'll be keeping an eye on the hands raised and chat box. So do please feel free, if there's stuff that pops up as we're running through the presentation, pop your hand up, and I'm more than happy to take questions as we go. So what do we mean when we say costing? So pure costing is about attaching patient activity information to the resources that we use, and that generates us a cost per unit. Now, when we say units, that could be a hospital stay. For our mental health services, it could be a crisis episode, it could be one of our community teams. There are a whole host of different activities that make up different units. The resources that we use to deliver those activities are also quantified. So it could be how many hours of somebody's time was involved in that hospital stay. It could be the floor space in the building that was used up by that bed. It could be the prescriptions that were issued to that individual. Now, once we've identified both the unit and the resources, that's what we can then trace back to itemised costs. Now, we do this using a set of national standards, and that's for consistency, and that is done in a system that produces effectively what we'd call a patient bill. So at that point, we can then understand for every patient that's coming through our doors exactly what they are costing the NHS. Now, the system that does this is what we refer to as patient level information and costing system, and that's where the acronym PLICS comes from. So you might have heard PLICS being talked about. We do have an acronym in the NHS. It is the system that drives all of our costing data. So costing doesn't just have to be PLICS though, and particularly for mental health, those of you that do work in mental health services, it's very difficult often to quantify for an individual patient those units of healthcare. Quite often we have long lengths of stay if they're in an inpatient setting. If they're in community, our patients can be with us for years. So one of the things that we've done locally is actually look at service line reporting as well. So this takes all of the costs relevant to delivering a particular service rather than just at patient level. And it considers how the costing data can be matched with income data that we receive for those services, and we can start to explore surpluses and deficits. It supports triangulation with other metrics, so quality metrics, for example, so we can start to underpin our contracting and our commissioning conversations. So I've got a couple of little examples on this slide here. The one at the top is our community recovery service and the one at the bottom is our acute service. We can see for our community recovery services, the little green dot there shows they're in surplus. Now, actually, what we've seen in community is we're running with really high vacancies. And generally for our community teams, because they are community provision, those vacancies don't tend to get covered. But the ripple effect of that is our waiting times go up. So when we're looking at them as a service line, it's important that we understand the whole context, because actually waiting times going up is not the positive message that we want to send. Whereas if we were looking at that green dot, we'd say, great, they're underspent, that's a really good position. Conversely, we've got our acute services with a red dot. and actually they are losing money. Now, in our acute services, some of the biggest pressures that we're seeing are observations, 1-to-1s, 2-to-1s, 3-to-1s, and actually having some really complex patients. So the kind of conversations we then have with our acute services are actually, are the commissioners paying us sufficiently for those services? And do we need to consider actually the income that we get per bed day, as well as looking at the resource that our patients are consuming and how that sits in line with our contract and the standard of care that we need to deliver. So service line reporting, we found, starts to add a lot of richness to those conversations in terms of using the financial data alongside other components to be able to have really meaningful conversations. So you probably started to think about why costing is important from some of the stuff I've said. It's about knowing how much resource we are requiring to deliver those services. I'm somebody that always has a thirst for knowledge, so understanding these sorts of things I certainly value. So actually being able to share across our organisation what resources are being consumed is really powerful. It supports the setting of tariffs or prices for payment. Now, in our acute settings, so physical health colleagues, payment by results has been around for years, and that is a tariff-based mechanism for payment in acute hospitals. Mental health services don't have that. So actually the use of costing data, certainly in our local system, has been really powerful in supporting us to think about actually identifying price points for things, so our commissioners can start to understand how much they're paying, for example, for our community team or an early intervention in psychosis contact. It helps us to benchmark against peer groups. So if we know other trusts that are delivering similar service, if we are both able to cost on the same level to the same national standards, we can compare, which then follows on to identifying opportunities to make efficiencies and also opportunities to improve patient care. It supports you to make the best possible use of your resources. So if you know that you have a finite element of resource, you can start to choose where you pinpoint that resource for maximum effect. And then finally, it supports our job plans and areas for investment or development. So there's a whole range of different uses and applications that can come about as a result of working with costing data. So following on, understanding our patient journey, costing absolutely can't be done in isolation. It is really important that clinical, operational and corporate teams work together on this. Without that richness of information, those who are accessing the costing system inputs won't understand how to map costs, and those being asked to then use the outputs won't understand where they came from. So partnership working is really important. That context gives us those building blocks to form the unit costs and to then take them apart again where we need to. We've had an example internally where we were using, for example, floor space allocations. And actually it took a site visit in the end to identify that we were working off of old floor plans and we'd actually got rid of a couple of rooms. And that was why the particular unit we were working with seemed like it was running with really high costs. Now, if we sit in a back office traditional function in a costing team, we wouldn't have known that, but actually linking in with estates colleagues, operational colleagues, that then starts to inform the information and ensures that what we're doing is accurate and meaningful. It allows you to ask the question, are we comparing like with like? Which is ultimately what we're aiming to do if we're wanting to identify variation and drive through those efficiencies. So our key inputs when we're thinking about that patient journey, we need to be considering our activity data. So how many patients are being seen and what type of patients are we seeing? We want to be considering the function of the wards and the clinics. So what type of patients are we treating? Do we have our wards structured by functional illness? Do we have them structured by age? Actually, are there any specific wards that are for specialist services that we need to be notifying? Job plans, literally who is working where and when. The buildings that we occupy, the IT systems that we use, and as you can imagine, there are a whole host of other inputs that are really important for the costing team to understand. A little flow chart at the bottom of this page here that gives an example of how we allocate cost for consultant. For ease, we've gone with around £100,000 for our consultant cost there. We would then be discussing with the service, actually, what does that consultant do on an average week? So here we've said 30% of the time is on a ward round, 30% of the time is working in an outpatient clinic, 20% is supporting contacts, and 20% is telephone calls. So that then allows us to take our total quantum of costs and apportion it out across all of those activities. Once we've got these different allocations, so we're saying, for example, £30,000 on ward rounds, we can then think about the activities those costs are allocated to. So the individual inpatients that were based on that ward who were seen, and the duration of the contact, the time that consultants spent with them. And all of these sorts of metrics get plugged into a system. And once we've told them all of those inputs, it can then generate an output cost that gives us that patient level costing information. So I'm going to have a little bit of a think about actually how are we going to use costing to improve patient care. So a couple of questions that we ask ourselves, and I'd be interested, I probably weren't expecting to come to participation in this session, but I'd be interested for some feedback as well from those of you on the call. So starting off, actually, what do we use to manage clinical variation? When you're working in operational services, what do you do to make sure that you're setting those standards and managing those variations? Secondly, how do we support better patient outcomes across all of our services? Thirdly, can we describe to our commissioners the increasing complexity and acuity of our patients? It's often a conversation that takes place locally where the feedback from the wards, our patients are sicker, they're coming in with higher needs. How do we evidence that? And then our fourth question on this slide is actually, how do we measure the value of new models of care against current models? So a lot of different things to think about. I'm conscious we're now up to quite a few of you on this call, so I'll be interested to see kind of actually what are people's thoughts on those questions that we're posing. Anyone want to come in? A nice quiet bunch today.
If you'd rather not say it out loud, you can put it in the chat box.
Feel free, more than happy to have comments and reflection in the chat box. No? Okay, so I'll talk a little bit about what we do at KMPT. So in terms of thinking about managing clinical variation, a lot of that does hinge on the data that's available. So one of the most powerful things for us to do when sitting with clinicians is to literally show them that information and play it back. So we've had various situations over the last probably 4 or 5 years where we've looked into job plans. And actually, when we've compared teams, so thinking about geographically, we have about 8 or 9 different community teams. We've been able to literally hold that mirror up and say, well, actually, this team over here delivers 8 sessions a week, and this team over here delivers 4. So actually sharing that information first off is really powerful in terms of exposing actually what is out there across the organisation. If we're starting to think about what we do with supporting patient outcomes, again, using the data that comes through our costing system, we can then work with clinicians to think about modelling different solutions. So I'll come on to talk about the specific area that we looked at KMPT in a little bit. But essentially, we had some consultants who were concerned that we were spending an inordinate amount of time sending out patient letters, sending out an awful lot of information that wasn't adding value. So actually we could work with them to say, well, currently you produce 8 letters and it takes 2 hours and this is how much we spend. Let's model that through differently and think about if we were only spending 2 letters and that was taking 30 minutes and it was done electronically. So we can start to think differently about using the data that we have access to to work with clinicians to model solutions that ultimately are better for patients. Very rarely have I seen innovations that don't focus on getting it right first time. Generally, they release cost. So can we describe to our commissioners the complexity? There are a whole wealth of tools out there that we can link into with costing data. So mHost is one that we're using at the moment in our organisation. There's also been various different data collections that's so care hours per patient day was one that was run a couple of years ago. Again, it relies on that costing information that is held within the organisation to be able to benchmark and think about what we should be doing. That then allows us to play back to our commissioners. Well, actually, we can tell that 3 years ago, this amount of resource was being consumed on our wards. Currently, this amount of resource is being consumed, and we can map that migration. And then finally, measuring the value of models of care. It's something that I say quite a lot on the training courses that I do. It's about value, and value is all of those metrics that sit around cost. So when we're thinking about value, it is about measuring the quality impact of things. It's about looking at benefits realisation. So costing on its own doesn't add a massive amount of value. Costing with all of the components that feed into it is really powerful. So it's about linking together all of those key components. So I'm going to talk a little bit about our approach now and just share with you some of the stuff that we've done at KMPT. So we came up with something called a deep dive approach that was really about taking costing information from historically being a very back office function and sharing it more widely and sort of making it much more transparent to the organisation. So what we devised was what became...
Really, so I'm in a meeting.
Oh, I've got somebody on, not on mute, sorry. What we came up with here was a 5-stage approach that thought about how we looked at all the key components of a service. So we started off thinking about which area are we going to look at, and we did this based on identified surpluses or deficits from our service on reporting. We then looked at reviewing that service. So actually what constituted the service? So what was our patient profile? What pathways were in place? What interventions were we running? We then took the interventions a little stage further to actually start to deep dive and understand the cost allocations and the resources that went into delivering those interventions. Step 4, we looked at our PLICS system. So actually, were there any accuracy opportunities? So like I mentioned earlier, sometimes we'd look at floor plans and realise they were out of date. Same can be true with IT systems. So making sure that we're definitely allocating the right overheads is key. And then step 5, we discussed with our care groups. So that's our clinical teams, we call them care groups. And we were able to apply their context and operational knowledge. So working our way through that process, that got us to an outcome which was about variation in cost. Now, if we felt it was warranted variation, so we understood why costs were different, no further action required. If it was unwarranted variation, that was where we took the piece of work forward and drilled into it in a little bit more detail. So the first one that we picked to work with was because we had a couple of consultants who were really engaged in our older adult service, and it was relating to cluster 18. So those of you that know mental health clusters, this links into cognitive impairment. And this was about people who are in the early stages of dementia, and its focus is very much on the memory assessment pathway. Now, the point at which we pulled this, we had a 233,000 deficit in the first 3 months of the year. So projected to head towards about £1 million loss. So definitely something that we wanted to tackle. So step 2, we started to review the service and really drill into it to understand what was going on. So for example, we pulled out all of the different teams that delivered activity in that service. We looked at the type of the contacts. So our blue bars in this graph are community contacts and our red bars are bed days. So instantly we were asking ourselves the question, if this is about a community service, why do we have bed days in our data? So a lot of stage 2 was about really investigating and understanding all those different components. We also looked at the length of the cluster review period. So how long were we keeping patients on our books? the recommended maximum review period as 12 months. But actually, we had 12% of our patients that were exceeding that. So really, do we understand what that patient profile looks like over that length of time? And then we also looked at our costings. So our nice green triangle here was how much we were being paid by our commissioners, and our red little dot over here was how much it was costing us. So instantly we had a mismatch, and we were getting a deficit per cluster review period of £411. You can see from the graph, though, significant variation in terms of cost across those cluster review periods. So step 3 was about looking at the dominant interventions and really starting to drill into those to understand what does that data look like when we look at our teams. Now, most of the activity for this cluster was delivered by our CMH top, so that is our older adult community teams. And we looked, for example, here at our activity count and our unit costs. So we could see that Dartford had our lowest cost per contact at £111. Ashford has our highest cost per contact at £264. Now, those of you that know anything about Kent, Dartford is very close to London, and actually our Dartford staff get paid London weighting. So were we to have speculated, we would have probably put Dartford towards the higher end. So again, it was about us unpicking that and thinking about why have we got such variation in cost. We looked at our durations, so how long were we spending on the appointments? Now, Dartford have got the shortest contact duration at 33 minutes, possibly linked to them being the cheapest. But interestingly, we've got Swale with 60 minutes. So again, significant variation in the duration of the appointments that are on offer across our services. For step 4, we started to look at overheads. Now, 64% of our unit costs was direct pay. So really important for us to engage with the workforce leads and really understand exactly how those pay costs have been allocated. Overheads were 18%. And we started to pick up themes from this. So your direct pay was varying hugely. Our facilities costs were varying from £2 a contact all the way up to £63 a contact. And that's where we started to think about, well, what buildings are we operating from? As I'm sure you'll have in the areas that you work, some of our buildings are rental buildings, some of them are very expensive PFIs, so there's a significant variation on estates costs. And then step 5, and most importantly, it was about taking this data and sitting down with key members in the care group. So they were able to provide us with the operational context that sits alongside this. So they were feeding through to us, for example, dementia, we should be having a 67% diagnosis rate. So how do we think about that with our patient pathways? Our time to diagnose should be 6 weeks. So when we're thinking cluster review periods, how does that tie in to the number of patients that are over a year, for example, with our teams? And then they were feeding through different information to us around referral rates and diagnosis rates. So all of that was then helping us to add richness to the information that we'd started to look at. The main bit, I mentioned this earlier around admin, that they started to pick up on was actually our process for memory assessment was very admin heavy. We were sending out a wealth of information to our patients that was confusing, particularly for that patient cohort who themselves were being reviewed for dementia and were having often older loved ones that were supporting them. And actually then when it came to the appointments themselves, we were asking people to come in 3 times. So we did some work to start to track through on some variation charts to think, well, actually, what was the average admin time? Now, this chart here tracks over a year, and it looks at the admin time to start with, and you can see it's quite variable week by week, but then it shows this red arrow here when we started to introduce a pilot. So actually, we streamlined the number of appointments, we streamlined the paperwork, and saw a significant reduction in admin time as a result. Now, clearly, we were then able to play that back through into our costing system and see what that did to the costs per contact and how that changed our service line position. So the outcome from all of this work that we'd started off, actually just by literally looking on a service line basis at something that seemed to be running a deficit, was we triggered a whole quality improvement project. So we refocused our initial assessments. Let's only do what's needed. Let's not put an awful lot of resource up front unnecessarily. Let's try to provide better patient and family experience, so driving up quality as well. Releasing our staff from assessment, so again, thinking about that really critical limited resource, we were consuming a significant amount front end on assessing people, but we weren't then putting in our resources back end to actually deliver interventions, group sessions, support to care homes. And our staff were unhappy because they were churning through assessments. And actually we weren't then adding the extra value support to our patients. We wanted to reduce the variation across the team, so some of the graphs I've shown you. Keeping pace with all of the initiatives that are going on, dementia has a huge focus nationally and it's something that we've got to tackle. And also setting ourselves up for a shorter time to diagnosis, so we don't have prolonged waiting lists and we're able to treat patients quicker. So ultimately it was about releasing our clinician time and putting it into the right place. So by offering increased initial assessments, because our assessments were now shorter, offering post-diagnostic support, we were promoting our patient choice. Our patients then felt happy and less burdened. So we were able to free up time for the post-diagnostic work, which then supported our local care homes and helped to improve the health input there. Our OTs were released to do their OT assessments and staff felt positive. There was much more time for them to spend with the more complex patients. So on something like this, actually it's about starting off the conversation with some data, with some information and observations, and sharing it with clinical operational colleagues to actually turn around a real positive change. So that brings me to the end of my slide deck here. Are there any questions or anything that anybody wanted to ask?
Any questions, Victoria?
I can see we've got someone typing in the chat box.
Hello.
Hi.
Can I just quickly say, so my name is Anna, and I'm the IAPT Information and Data Manager, and I'm just dealing with data. Sorry, I'm just hearing myself at the same time, so I'm not sure why. But can you hear me? Okay. Hello. Yeah. Okay. So yeah. Thanks so much for that. It's just, yeah, I just wanted to thank you because it's really valuable to see how the data is being used. Because I was asked, quite without any background information, to deliver the information for PLICS from the IAP perspective, and that was basically a table full of the appointment, full of with the appointments and all the appointment level information for all the clinicians within 1 year. So, and also all the so the columns required and the extra columns with the calculations. Basically, now I understand more and what they're doing and where they're going to, basically. But yeah, it was to calculate how much we spend on delivering care, bottom line. And I think that's really good to see. Though what I could say is I'm not sure exactly what the feedback was from that. So probably that was taken forward, analyzed, and then something must have come back, because next time round I think we're thinking a way of doing this, or maybe for the team to actually extract the information straight from the data warehouse, because that's ready, it's available. So yeah, I guess that was really useful to know. So thank you very much.
Thank you, Anna. It's difficult, isn't it? Because sometimes you can feel like you're feeding information in somewhere and you've got absolutely no idea of what happens. And it's something that's massively important for me. A lot of the training that I do is about being transparent in terms of how that whole process works. I will be honest and say when I joined KMPT, it was quite a back office function in terms of costing. We had all the wealth of data, but it wasn't really used. So I know it's really variable across different organisations, actually what those outcomes do. And part of sort of these sorts of training sessions are about raising the profile of what can be done and how powerful it can be when you do take that data and share it and use it positively. I've just seen, Miriam, you've added as well about who would you approach to. So every NHS organisation within their finance team will have a costing lead. They might have it as a separate function. It might sit within a financial management team. But I'd start off by asking the finance team how they gather their costing information and whether they do service line reporting. So Miriam, without obviously knowing which trust you're in, I don't know who I'd link you in with. But yeah, I'd start off there in your organisation and see what they say. You can see we've got another message coming as well. I would just add as well, so in terms of costing, we are all required, and mental health is now mandatory as well. We have to submit this data nationally. It goes up as part of a national cost collection. And that's normally done in about June, July time. So Anna's picking up your point about obviously learning for next year. What should happen in your organisation is they should look at those year-on-year comparisons as well. So for us, we've noticed a real trend in acute. So our acute inpatients, we're seeing significant rises in cost where we're using far more staff. So that's come through annually, year on year, and that's now been something we've raised with commissioners to say, actually, we're noticing this as a healthcare trend here. What can we do about this? Emily, so where can we access benchmarking for similar teams? Are you familiar with Model Health System by any chance? So I would say that's probably your first port of call. That's fine. It's not something that everyone's aware of. So Model Health System, it's a national database. The web address, let me see if I can remember the web address. It's literally like model.nhs.uk. Yeah, that's literally model.nhs.uk. Anybody can sign up if you work for an NHS organisation. It's a really simple registration form and it's normally turned around the same day. The national team are really quick. It can be a little bit overwhelming when you log into it, but essentially held within it is loads and loads of benchmarking data for all sorts of different services. So it can be a real wealth of information, particularly if you're thinking about a particular service that you work in, and it will show you everybody else's data nationally. And it's not just cost, it'll look at quality, it'll look at all sorts of other bits as well. They also do webinars as well too, so if you want any sort of training, they've got some really good videos that talk to you about what it is, so do have a look. Anna, I can see, oh fantastic, thanks Anna, that's the link.
That's great, thank you. Yeah, I was just thinking this modeling that's being used is also used for forecasting, right? To expect increases or decreases in workforce.
Yeah.
Okay.
Absolutely. Yeah, and for planning too, and business cases. So we're doing a big business case at the moment for early intervention in psychosis. For anybody that knows kind of what's come out with the long-term plan on that, there's a big push to set up at-risk mental state, so ARMS is the acronym, services that form part of the wider EIP. Well, actually, in order to do that, what we've seen through studies in other organisations is that trusts who have an ARMS service, it diverts activity away from EIP, treats patients slightly differently, and then has a bit of a ripple effect. So taking the costing data, we can think about, well, how much does it cost us currently to treat patients through our EIP service? We're working with the team to then model what does an ARMS service look like. And you then start to plot and think, well, actually, okay, well, if we're saying 16% of those patients are going to move across, actually, what impact does that have on both services? So, yeah, it's not just about historic, it can be used to future plan as well. Any other comments, questions, anything else you want to ask? Nope. Fab. Obviously, I'm a massive fan of costing and hugely enthusiastic. So if anyone wants to get in touch, please do. I'm more than happy to have one-on-one conversations. That's absolutely fine. I'll hand back to Sophie.
Well, thank you everyone for attending today, and thank you Victoria for taking the time to teach everyone about costing. We shall send out the recording and the slides for the session later today or tomorrow. Thank you very much everybody, and then speak to you soon.
Have a good afternoon, everyone.
Thank you.